Welcome to this special session on the healthcare value analysis concepts for the infection preventionist, where we look at an established collaboration that's destined to improve clinical outcomes. My name's Hudson Garrett, and I'm an assistant professor of medicine in the Division of Infectious Diseases at the University of Louisville School of Medicine. And I'm pleased to be joined by Karen Niven, who's the Director of Performance Groups for Premier, as well as the President-elect for AVAP. And we look forward to your questions during this session. Since we're offering continuing education for today's program, please find our conflicts of interest as required by CE. Our objectives for today are to really look at three basic things. Number one is, what in the world does the infection prevention and control process have to do with value analysis? And how is that going to be different in this post-pandemic healthcare environment? The second thing we'll look at is the overall steps in the value analysis process to ensure that not only are we guiding optimal patient outcomes, but we're also reducing the overall risk profile in a very dynamic environment. And lastly, and probably most importantly, is how do we collaborate with infection prevention and value analysis so that we have a shared goal of improving the overall delivery of clinical care? So the Institute for Healthcare Improvement has probably done the best job in defining what the overall value in healthcare really is. And they call this the triple aim concept. And it really looks at three fundamental tenets. First and foremost is improving the population health. So we know that we as a healthcare system, whether we're inpatient hospital or an outpatient group, an ambulatory surgery or skilled nursing facility, all have a population that we're charged with serving. That's our patient population. We want to provide the most optimal care at the most reasonable cost in the most efficient manner. The second area is overall patient satisfaction. For those of us that work in the inpatient environment, this is the HCAHPS scores. This is our Press Ganey and other types of metrics that we might use, but the patient satisfaction is critical to the success of our reputation in the community, as well as our service lines that we offer. Those that work in large integrated health networks know this very well, because this is also a metric of how we're paid. Our compensation is going to be driven in part by the way that we perform in the eyes of our patients. Things like, is the room clean? Do they feel like the staff listened to them? Was their pain well controlled by their provider team, as an example? And then last but not least is another part of this tenet, which is decreasing the overall cost of care provided, right? When clinicians especially hear the word decreased cost, they think of budget cuts. And you'll find today, especially in Karen's part of the presentation, that value analysis is not about cutting money. It's really about improving the overall value of care that we provide, but also saving costs in a way that is efficient, effective, and also in line with evidence-based practice. So what in the world is value analysis, right? Most infection preventionists do have some involvement with the value analysis process or the product review process, as some people may think. But Premier defines this very effectively: an evidence-based process for healthcare organizations, right, that are actually trying to obtain supplies, services, and equipment. And it really is that value analysis process that drives the quality care delivery, safety, and outcomes, and factors in total cost. Well, essentially, that is directly in line with what we do in infection prevention, right? In infection prevention, we're trying to reduce costs. We're trying to improve the quality of care. We're trying to make sure that patients don't get that preventable healthcare associated infection. So if you look at these two things, they're quite congruent. Value analysis has the same shared goal as infection prevention, which is really what brings us here today to the summit. So why do we on a bigger scale even do the work of value analysis? Well, there's a couple of different things, right? Certainly we can standardize the care that we provide, which is going to improve our ability to do things in a consistent manner. We know that consistency in healthcare is key. Imagine the last time that you checked into a hotel and you went into your bathroom in the hotel and you found that there were 2 washcloths, there was a shampoo and a conditioner, a soap, probably 2 towels. It's consistent, right? Regardless of where you go, you consistently have the same types of things. That standardization in places like the operating room, the emergency department, intensive care, oncology clinics, that could go on forever, is going to afford us efficiencies in how we deliver that care. The second area that we need to focus in on is pricing optimization, right? If I buy all of one thing, for example, if I have one type of adhesive bandage for the placement of IVs, as an example, when we remove that catheter, versus having 6 different ones, it's going to simplify our inventory management. It's going to make our price better. We're going to be more GPO compliant. right? And that's going to afford us additional cost savings initiatives. And then last, but certainly not least, is things like Six Sigma and lean management. If you're an infection preventionist or a value analysis professional and you're not familiar with those concepts, there are great resources out there that allow you to learn those skills and earn those two certifications. But Six Sigma is all about eliminating deviation. We want to do things in a consistent manner that's going to give us the best chance for success. And if we lean the process, we're trying to remove unnecessary things, waste and redundancies, and ensure that what we're doing is highly efficient and is going to deliver upon our promise to our patients. So there are some value analysis guiding principles, right? And first and foremost, just like in infection prevention, we need good leadership support. If we don't have a good engaged leader at the very top of our process, one that is actively engaged in the value analysis committee, then that's going to be a problem for us, right? We know that it's important to have that leadership support to remove those obstacles, remove barriers that might be there, to bring resources to the table, to solve some of those more administrative issues where maybe we're not getting cooperation, for example, from another individual that we need, right? That's really their purpose there. It also signals to the team that at the very top echelons, right, of our organizations, that the C-suite is not only aware and engaged, but they're there to help problem solve, right? Now, part of this is going to be defined by who we have at the table, right? Imagine if you invite your top 10 friends out for dinner and you're sitting out at a nice restaurant and you look around the table and you say, well, I've got a dermatologist, I've got an internal medicine folk sitting here, I've got a pediatrician, I've got a psychiatrist, I've got a pharmacist, right? And you can see my point. You're building a diverse care team that's going to be able to solve the complex issues that we face in healthcare. The same is true with value analysis. I want a broad representation of different functions within healthcare, right? I can't just have one group of clinicians. I cannot just have nurses or just techs or just value analysis type folks or purchasing. It has to be a collaboration amongst all of those. Now, part of this is built on trust, right? And if we don't have trust amongst those key stakeholders, then it can be very difficult to move the needle forward and also really execute on some of these initiatives. These relationships that we build are going to be critical to the success of the team, but also the broader health system. And last, certainly what we always want to do is track our success or learn from our failures, right? I know that in my career, I've probably learned more from my failures than I have from my successes, right? If we look at our successes, it tells us what works. But if we look at our opportunities for improvement, those are things where things didn't go as planned, but we can use those as learning opportunities to enhance our future. Now, in infection prevention, right, our goal is to prevent preventable healthcare associated infections. Value analysis shares this exact same goal, right? Now, it is on a broader scale for them because they're looking at this on a health system level across all products and services that we might utilize. But their primary aim is to improve the patient's overall clinical outcomes. And so we share that, which is great. So we have common ground up at the very beginning. The other thing that we have to consider in this post-pandemic world, right, now as we continue to hopefully emerge from COVID-19, is that it's not just about patient safety any longer. It's really about healthcare safety, right? We know that it can't just be about protecting the patient. We've seen, unfortunately, many of our colleagues contract COVID-19. We've got friends and family that contracted COVID-19. And so the term patient safety has really, in a way, become antiquated. And now we have to look at overall healthcare team safety combined with patient safety, right? We can't take care of patients if we don't have healthcare workers. And if we don't have well healthcare workers that are at the bedside available, then of course we have a major issue. The next area that we have to explore is how do we make care more cost effective? Well, this can be difficult sometimes. Sometimes we have to do a little negotiation. Sometimes we have to do more investigation and vetting and due diligence. And that's where many of our GPO partners can come in to help us on a national level with this value analysis process. There's also certain organizations out there like the ECRI Institute that look at an unbiased way at different supplier products that are available, provide cross comparisons and references, and can be very helpful, especially for large health systems that are looking to decide what is the right product to use for them. And last is to use a data-driven approach, right? We collect tons of data in healthcare, but often we don't do anything with it. And so my rule of thumb has always been don't collect data without an intent to do something with it. We don't ever want to do that. That's not only a waste of our time, but it also can put us at risk for liability. As we collect data on these different efficiencies and what we're doing in value analysis, this can help us drive better practices. This is something that can be used to actually share in publications, to really learn from other individuals. This is where listservs and some of the other tools that we have accessible and through our professional organizations can be very, very helpful. Now, there are some regulatory aspects that really impact infection prevention from a product and service perspective. And I thought it would make sense for us to break these down into three basic buckets. First and foremost, on the left, you'll see here is the regulatory bucket, right? And that's going to be closely followed by our accreditation standards as well as our clinical standards of care. So let's look at these sort of individually. From a regulatory perspective, this means this is the law. We must do this. Now, it doesn't mean necessarily, ironically, that this is evidence-based. For example, let's say that OSHA puts something out that says you must do this. And I'll just use the Bloodborne Pathogen Act as a perfect example. That is a law. It is a regulation. It is something that we must follow in all of the states. However, it may not be seen as evidence-based because it's not produced by the CDC. It's not produced by a clinical organization at all. But it is a regulatory body, and therefore we must comply. Both the FDA and the EPA, you'll see here in just a moment, actually regulate the different products and services that we use in the infection prevention field. And so you'll see that most all products will fit nicely under one of those two buckets. And you'll see potentially that there's also some overlap, and we'll talk about an example of that here in a moment. And lastly, one that you may not be familiar with, especially as an infection preventionist or as a value analysis professional, is the Department of Transportation, or DOT. DOT specifically regulates the transportation of medical waste, right? And so it's important that we are aware of those waste regulation guidelines so that as we dispose of waste, like regulated medical waste, we're doing so correctly. And this is going to come in very specifically when we look at waste transportation vendors that we might use in the healthcare sector. The second bucket there in the middle is accreditation, right? Most of us have some type of voluntary accreditation. Especially in the hospital setting, it is extraordinarily rare to find hospitals that are not accredited. You'll see this increasingly in other settings like skilled nursing, potentially specialty clinics like oncology. And we find that there's some environments like the dental practices that are not regulated at all. But the three big guys that are really in this sort of area are the Joint Commission and DNV, which primarily regulate the inpatient environment, but also regulate outpatient settings. And then HHC, which is going to regulate our outpatient ambulatory surgery centers. Each of these organizations has one same goal. They want to make sure that they are accrediting and sort of helping to license, if you will, each of these healthcare facilities, and that we're doing the correct things. Many organizations are actually using these accreditation bodies to meet federal requirements through CMS. CMS deems these authorities as designated and deemed authorities, meaning that they can go out and act on the behalf of CMS and inspect the facilities to ensure that they're compliant with current regulations and standards. Last but certainly not least is our clinical standards of care bucket. These are primarily big organizations on a national scale, like the Centers for Disease Control and Prevention, or the CDC, or our professional associations. For example, if you are a perioperative nurse and you're looking for good guidance in the OR, then you're certainly probably going to go to the ARN. Right? They have guidelines that are specific for the operating room and perioperative practice. That's going to be where you're going to go. But for the most part, the Centers for Disease Control and Prevention, specifically their Healthcare Infection Control Practices Advisory Committee, otherwise known as HICPAC, are really the core areas that we're going to reference when we're writing policy and procedure, doing evaluations of infection control products, and really looking for what are those evidence-based practices that we need. And I'll give you an example of the checklist that's available through the CDC for product evaluation here in just a moment. So primarily, we've got two organizations, as I mentioned, that own the majority of the infection prevention products. Now, this is not to say that there will not be certain products that don't require either of these regulatory approvals, right? And I'll give you an example. A UV piece of equipment. It does not require technically EPA approval, and it does not require FDA approval. You may have a factory that is approved to make these from the EPA perspective, but maybe the device itself is not registered, right? That's not a requirement now under current law. And so that could be an example of not only where a product straddles the fence between the EPA and the FDA, but where there is a regulatory sort of gap in the armor there. But the way that I keep this simple is that the FDA is going to really regulate any product that's used either in or on or inside, right, a human body. Whereas the EPA is going to regulate all of the things that are used on non-living environments and surfaces. So with the EPA, you'll see things like disinfectants that we use and cleaning agents. Whereas the FDA, you'll see here in just a moment, have a ton of responsibility across many different products that are used within the healthcare setting. So the FDA, by definition, is the Food and Drug Administration. And so many people, rightfully so, think it regulates the food and supply and drugs, but it actually regulates much more than that. Some of these are going to be particularly important when we look at overall infection prevention. And let's just start with the most basic: food. Well, as an infection preventionist, part of our job has to be to prevent healthcare associated infections, but also think about foodborne outbreaks. So for example, let's say you're on the value analysis committee and there's an RFP that comes up, and it's for your food services provider that's going to run not only your cafeteria for your inpatient population, but also all of your snack bars, right? Your sort of fast dining locations, your coffee shops. Well, the infection preventionist may think, well, I'm not sure I need to be involved in that. It's food. Well, you absolutely need to be involved in that value analysis discussion, because we know that food can cause foodborne outbreaks, right? We can have foodborne illness, things like norovirus. And so it's important to track that type of stuff. They certainly regulate drugs, right? And medical devices. And we know that drugs are broken down into two basic categories: both prescription or RX items, as well as over the counter, right? Drugs have a huge impact on infection prevention, not only in preventing and treating infections, but also causing them, right? For example, if we look at C. difficile, which we're very familiar with as infection preventionists and value analysis professionals, that is caused by the overuse of antibiotics. But yet we treat it for the most part with more antibiotics. And so that's sort of an oxymoron there, in a sense that we have certain organisms that we are trying to prevent or deal with from an antibiotic perspective, but we're still using that same causative agent to actually treat them. We have other things like vaccines, which we know has been particularly important during the last 2.5 years during our pandemic, blood, biologics, cosmetic products. If you have any type of animal or biomedical research, that certainly is going to be regulated here as well. You have radiation emitting products, and then lastly, tobacco products, which hopefully will never be a problem for us in healthcare, because certainly we want to keep our patients and staff away from that last part. Now, a couple items that we would all be familiar with that fall into that FDA bucket are things like hand sanitizer, right? Which is carefully regulated by the FDA, and for good reason. This is both our normal hand sanitizer as well as things like that we might use in the perioperative environment for our pre-surgical scrub. They regulate skin antiseptics and all of the personal protective equipment, which again has been a big issue for us, both in supply as well as ensuring there's a vetting process for products that are coming into the country during the last 2.5 years. We mentioned earlier that they regulate drugs like antibiotics, which are really the biggest class of drugs that are going to be specifically important to discuss here from an infection prevention and control standpoint. Laboratory tests, things like our COVID test, rapid streps, right? So this is really everything from point of care all the way up through those complex laboratory tests that we've been done in either hospital or regional reference laboratories. Medical equipment, surgical instrumentation, as well as gloves, right? This is not meant to be an all-inclusive list, but just a few examples that we can all relate to that fall under that FDA bucket of regulation and certainly have direct infection prevention and control implications. Now, the EPA on the other side is going to regulate a smaller group of things related to our field, right? And primarily pesticides and healthcare grade disinfectants. There is the law out there called FIFRA, which stands for the Federal Insecticide, Fungicide, and Rodenticide Act, which is definitely a tongue twister, right? But this is a specific regulation that governs the use of EPA registered products. Imagine years ago when we saw all the teenagers that were huffing hairspray, right? Believe it or not, hairspray, because it's compressed air in there and it's under pressure, is regulated by the EPA. The EPA has very specific regulations about appropriate usage. And so it essentially says, you need to use this product in accordance with the manufacturer's instructions for use. The same is going to be true with our disinfectants, right? And the disinfectants are not only approved at the federal level on the EPA scale, but each state also has some type of regulatory approval. So it can take some time to get new disinfectant claims or new disinfectants approved. Now, this can certainly be expedited with certain pathways that the EPA has, especially during pandemics or large scale outbreaks, but that's not always a pathway that we can rely upon. And lastly, the EPA has done something that I think is very helpful. Years ago, when we started to see these emerging viral pathogens, they sat down with the CDC and said, how can we come together to look at the overall science and develop essentially an algorithm that will allow us to approve products for claims that they're not tested for. And I'll give you an example, Ebola virus disease, which of course we dealt with several years ago, and we continue to see intermittent outbreaks over in West Africa, is not typically a claim that you will see on a disinfecting product, right? And for obvious reasons, no laboratory technician or no lab in the United States wants to bring that into their laboratory. Certainly from a safety and security standpoint, we don't want to actually have laboratory technicians handling that outside of controlled BSL-4 labs. And therefore, the EPA says if you have sort of a surrogate organism or something that's similar that you've already tested against to the identified pathogen, in this case, we'll say it's Ebola, then you can say that you're effective against Ebola, right? And so again, we see sort of this emerging guidance that can be particularly helpful for infection preventionists, as well as our value analysis colleagues in dealing with some of these more emergent threats. Now, there are some product considerations that we have to think about, right? First and foremost is, does the product have the necessary regulatory approval if it's required, right? So as I mentioned earlier, UV machines used for disinfection of rooms are a perfect example. There's not technically a requirement by the EPA that they be approved, but you'll see in many instances, manufacturers will say, well, we're approved as an establishment, right? That only means the factory in which they're produced is actually approved. The device itself is not. Doesn't necessarily mean it's a bad thing, but it also means that it's not undergone the rigorous approval process that the EPA has before it, right? It allows us to have some sort of integrity of the process and independent review. The second area that we have to consider is really more institutional, right? If we're saying that we want to target, for example, C. difficile, then does this product actually target that? And do they have an established claim for that? All right, sort of the third area is it going to help us be compliant with the evidence-based guidelines that exist in the space? Having a little brother that's an attorney that works in healthcare and has also dealt with some malpractice issues, I've learned a lot from him, right? And he always goes back to this sort of fact that evidence-based practice is one thing, but when you have a policy and procedure that you don't follow, you're instantaneously setting yourself up for a failure. And there's a lot to be said for that. We certainly want to look at GPO compliance, which my colleague Karen will be talking about as she works at a GPO at a very strategic level, but also works in value analysis on a national scale as well. And then lastly, we have to consider the overall cost of ownership. And what does that really even mean? Is that only the purchase price, or is that something more comprehensive? And probably one of the most important aspects and questions in my eyes is, how do I get support to make sure that this implementation, if I move forward, is going to be a success, right? With recent budget cuts as well as staffing challenges, vendors may also be short-staffed. And so we want to ask and understand what the true implementation support available is so that we can do each thing successfully. Now, from an efficacy standpoint, we want our products to be very effective. We want them to be effective against not only the sort of core element things like bloodborne pathogens, but also against some of the specific pathogens that we're facing in our facilities. One of the best ways for the infection preventionist to work with value analysis in this space is to use established tools like the antibiogram. If you're not familiar with an antibiogram, it essentially says sort of, these are the organisms and isolates that we found in our patients, the bacteria. And then here's the effective antibiotics and the antibiotics that are also not effective, that are resistant to these things. Now, I'm not interested in the antibiotic effectiveness, right, in terms of value analysis. I'm really looking at what organisms are we commonly seeing in our patients? How do we make that available to the entire value analysis team, and specifically to infection prevention, to drive this conversation about true broad spectrum efficacy? Generally speaking, the checklist that I use is listed here on the slide. So I want to make sure that the product is effective against gram-positive and gram-negative bacteria, our enveloped and non-enveloped viruses, our pathogenic fungal organisms, most notably things like Candida. Certainly from a regulatory perspective, we've got bloodborne pathogens, which is going to include a minimum of HIV, hepatitis B virus, and preferably hepatitis C virus. From a disinfection standpoint, you may hear the term microbacterium or intermediate level disinfectant, which essentially means that that disinfectant has been tested against a higher class of organisms that is typically more resistant to making it inactive or killing it. And so you'll see sometimes that disinfectants will be tested against microbacterium. It's important to note that the CDC guidelines for disinfection for our non-critical surfaces require a low-level disinfectant, but some may elect to also use intermediate. You could certainly look at bacterial spores, right? Keep in mind that disinfectants, just like hand hygiene agents, are not going to be effective against all bacterial spores. Really, with hand hygiene, our goal is to not kill the spore, but to physically remove it. With disinfection, we may actually be able to kill the spore like C. difficile spores if we use a sporicidal type product according to the labeled instructions for use. And the last bucket is one that particularly has been troublesome for us over the last 2.5 years, which is those more novel pathogens like the SARS-CoV-2 virus, which causes COVID-19, right? Again, we're trying to make sure that we have a good representation to determine whether or not this product is effective and it's going to have the efficacy that we need. Now, how do we assess a product's claims, right? And I really like this slide because it talks about sort of the fact-checking process, right? First and foremost is that our vendors, we want them to be good partners. Part of that partnership requires integrity and trust, and to ensure that we can rely upon what they tell us, right? That being said, we've all been burned before, right? We've been burned before by salespeople or other individuals that work in industry. And so it is important for the integrity of the process, as well as the overall safety for our healthcare system and reducing the risk profile, that we double check things, right? And we really want to look at the product's full approval, whether that's from the FDA or the EPA. These are public documents. You can go to fda.gov or epa.gov and search for this information and readily find it and really use that to your advantage. Some products may have technical data bulletins or other data sources that review some of this information, and we can certainly combine that with published peer-reviewed literature that is available out there in the space with Medline searches and some of the other basic tools. If you have access to a medical librarian, especially if you're part of a larger academic health system, this is a great way to get them involved and actually have them do a product search and go out there and look in the literature and see what's out there. If you're not familiar with the FDA's MAUDE reports, this is your medical device adverse event reporting system. The same is going to be true. There's a system also for drugs, and so we've got that available to us. There is not one of these types of systems available through the EPA, unfortunately, for those products. But I frequently look at MAUDE reports to make decisions about medical devices and understand not only causality or potential causality, but specifically looking at how can we make sure that if there was a mistake or there was an issue, that we also avoid that. And so it really is a lessons learned tool, not only from a proactive standpoint, but also reactively. And the last two areas are really good vendor partnership, right? You can move a vendor from a vendor category to an industry partner when you have the right trust built into the system. And when that company is equally as invested in your success and the success of your patients as you are, right? And that's hard to find, but I see increasingly more and more industry professionals are trying to be much more of that consultative approach versus sort of that hard pushing of products. And we know that our vendors and our suppliers bring instrumental value to the process of value analysis. They are the ones that are bringing these clinically innovative products. And so we want to maintain open communication that's transparent and is also meeting our facility and institutional regulatory guidelines. So how do we build this collaboration as infection preventionist with value analysis and as value analysis with infection prevention? Right? Well, first and foremost is to extend that invitation to make sure that there's a welcome spot at our table so that all of these different parties, these different specialties can be involved, whether it's infection prevention or sterile processing, it doesn't matter, right? Each of these functions is going to be important, but infection prevention has to own sort of the review of this. This is important. And we see this even with the FDA now, where there is a medical device infection control branch within the Food and Drug Administration that is reviewing all new medical devices to look at things like reprocessing. Is this something that can, from a human factor standpoint, be deployed properly? And even FDA has brought in a PhD level human factor scientist that is helping to sort of root out some issues with medical devices that might be troublesome for us. And we also have to consider things like, how do we in-service this? How do we actually break this down into a way that's going to be effective for our teams when we have maybe 15,000 employees, right, that have to be educated? This can be an extremely enormous task on a good day with a ton of resources. But standardization, right, is going to be an important element of this overall process. We want to make sure that standardization is seen as an opportunity to bring better standards of care, being more consistent with the way that we deliver care. It can help us with inventory and spend and sort of the distribution and logistics component. But it also, from an infection prevention standpoint, ensures that we have confidence in what we're doing. I give you a perfect example where I worked with a facility years ago that was seeing a lot of CLABSI infections with their central lines. And they started pulling data, and thank goodness for materials management and value analysis. They said, wait a minute, we've got 7 different central line insertion kits in the health system. There was an astute value analysis director that was brand new in the role, and she immediately took that by sort of the reins and said, we've got to fix this. Not only can we not get to the root of the clinical issue, we have a massive standardization problem that is creating logistical nightmares with different suppliers because they were also different suppliers. And so that's going to be an important element here. And from a product evaluation standpoint, we want to do this in a data-driven approach that is going to be rooted in what the evidence-based outcomes are that we're seeking, that's always putting the patients and the staff first and in sort of the center of that safety equation, that is going to be compliant with our regulations, whether it's from OSHA, CMS, or others. Certainly, we want to look at best practices, not only within our organization, but also on a national scale. That's where professional associations like ARM or APIC or AVAP come in to help us drive some of those national practices about what our peers are doing that work or don't work. And lastly, like always, we want to look at that total value proposition of the total cost of care or other financial influencers that are going to help us make these decisions. Things like GPO compliance or who's our prime distributor? How will we move the product in? What's the cost of sort of movement of a product in from that perspective? And so from this standpoint, the CDC's HICPAC group, again, and HICPAC is the Healthcare Infection Control Practices Advisory Committee, really helps the CDC author independent guidelines that are used in the infection prevention control space. So this slide, as well as the one directly after it, really look at a product review worksheet. We'll make sure this worksheet is available to you in a PDF format so that you can download this to use in your product evaluation. But basic things like, does it have the appropriate clearance from the EPA or the FDA, right? What is the sort of intended purpose? What are the clinical outcomes that we're trying to achieve, and are they documented in the literature? What are the indications or the label claim that we're trying to use, right? Is the product marketed specifically for infection prevention? We've talked about efficacy and safety as to what that is. They then go on to sort of look at a bigger scale and sort of getting down into the more granular level of what's the safety and efficacy, right? Is there an assessment of balance versus harms versus benefits, all the way down to the resource implications? I would strongly encourage us as value analysis professionals and infection preventionists to use this tool to our advantage. It provides a systematic way that is really rooted in science that's going to help us be more compliant, right, to make product-based decisions. This is also extremely defensible for health systems to use this tool because it is produced by the CDC. So it is a national best practice tool that can help us benchmark. Now, sometimes in healthcare, we hear the word industry and we think that that's automatically bad, right? I don't look at it that way. Having worked on both the clinical and the industry side as a clinician in industry, I understand both sides, right? And I think both sides bring tremendous value when the relationship is proper and it's transparent and it's really with the patient's best interest at heart. But industry does bring good value to us, especially in the form of clinical improvement in either processes or products. They also bring clinical innovations that help us not only diagnose, treat, but hopefully cure many more patients, right? And so how those products are used will help us improve those outcomes if we do it effectively. Part of this is to look at pricing and ensure that we have good transparent pricing, that our value added components are present there, things like in-service and sort of routine competency assessment, and then having a strategic conversation about how this particular technology or product fits into our bigger needs, right? If a vendor walks into my office and has never understood what our strategic values are as an organization, then I really don't have a big interest in working with that vendor, as sad as that is to say. I want someone who's going to be partnering with me on the front line, somebody that during the pandemic is still going to answer my call, right? I remember people saying, well, you actually answered my call on the weekend and you actually returned my call in the middle of the night because you knew it was an emergency, right? This is an important element of partnership with industry. Now, one of the components that we must consider before I transition to my colleague Karen is training, right? And I want to be very careful in the use of word training. Training does not equate to competency, right? We've all worked with somebody who is really well trained, but probably pretty incompetent in their role specific task. And so it's important to develop training and competencies based on the individual role of the healthcare professional. Maybe a nurse is going to be very different than a provider. A provider is going to be very different than a pharmacist, right? And so all of these roles come together, and they may all use the same products and services, but we have to do so in a consistent manner that's going to protect the healthcare workforce. Now, there's a couple things that come to mind, most specifically with anything that's considered hazardous by OSHA. We need to train in the hazardous communications or HAZCOM training requirements, right? Generally, though, for products, training needs to occur at the time of hire or also implementation, right? So if we're implementing a new product, at least annually, I noticed that I said at least, and so preferably you may want to do that even more on a different cadence. Good example of this is when we think about CPR, when we take basic life support or advanced cardiac life support. These are classes that we lose those skills after 90 days. The data shows us that if we don't actually put those skills into practice. And so you'll see organizations like the American Heart Association, which are recommending quarterly skills checks for these life-saving things. We may need to look at this for certain products that are especially high-risk medical devices. Now, if I'm using that product every day, all day long, you probably don't need anything more than annual competency, but you do want to do routine spot checks to assess for proper utilization. And then lastly, but probably most importantly, is anytime we change a product or process or procedure, anything about that, we need to retrain and document that, document. I can't stress that enough. That training should be specific to the individual role, as I mentioned. So a critical care nurse is going to be different than a pharmacist, which is going to be different than a certified nursing assistant. And it's got to be appropriate product usage that's going to be part of that training, as well as some of the tools that might be associated with this, like the safety data sheet, that are important elements. So with that, I'm going to transition over to my colleague, Karen, who's going to sort of walk us through the value analysis process in more detail, and then we'll see what questions you have at the end of today's program. Karen, I'll turn the program over to you.
Thanks, Hudson. So Hudson's done an amazing job of setting the stage for, or setting the table, if you will, for how you connect value analysis to, for this presentation, infection preventionist. But I would take that a bit further to say, you know, value analysis is not a thing we do. It is a way we do all things. We create value analysis teams that are multiple disciplinary, as Hudson laid out. My background in my clinical days was perioperative. It was extremely important for me when I was developing and looking at process improvements, new products, continued training on current products, that I had a multiple disciplinary team. I had the scrub techs, I had the anesthesia providers, so that we would, all the patients, all the practitioners that participated in the patient care in the perioperative world were at the table. Because I had a general surgeon colleague friend that told me, Karen, if you're not at the table, you're on the menu. So I wanted to make sure that all of our practitioners were at the table so they had a voice. You'll see listed there in the bullet some of the things that you may consider. And it leads with the infection prevention, because if the last 2 years have taught us nothing, it has taught us to bookend what we do within value analysis and in clinical delivery of care and infection prevention. That certainly doesn't leave out the other practitioners, which in the perioperative world, the sterile processing team was at many times the most important part of the care delivery chain. It's also really important that you have C-suite, as Hudson said earlier on in the presentation. It's very important for a value analysis process to have C-suite endorsement. This is the time for value analysis to be at the table, because we have learned over the last 2 years the importance, and it's not just new product introduction. It is the look at the value of the product to deliver the quality of the care. So you need C-suite to understand, endorse, and if they are so inclined to be a part of the process. You also must have a co-chair. It needs to be structured in a way that you have positions that are established and that can provide leadership as you work through the development of these teams. But I would just go back one more time prior to going to the next slide, where we would say that value analysis is the way we do all things. So as we look at the next slide, you'll see that it is the important portion of the financial implications of the clinical value analysis. So you'll see that you need to have, I call it the math problem. And the math problem includes many different portions, many different variables. So it's important for the clinician to understand the math problem. So as you can imagine, coming out of the perioperative world, it was really important for me, for our scrub techs to understand how much a stapler cost, so that they knew which physician was going to use one stapler, but might not use a second one. So would they open that second stapler? So it's very important for all the practitioners to understand the financial implications, or the math problem, if you will. In many of the teams that I worked with, they assumed that you got paid for everything that you used. And as many of you know, that's not necessarily the case. So it's very important for all in the value chain to understand the coverage, the coding, and the payment, because that does lend credence to the different portions of the math problem and the different value that these attributes pay. So as we move to the next slide, you'll see that I'm gonna talk a little bit about knowing your GPO partner. And I use the word partner intentionally, because your GPO is your partner. They can help you with information, they can help you with product information, they can certainly help you with supplier connection. You know, one of the things that we've done over the last 2 years is work through some product disruptions. I encourage you to reach out to your GPO partner to help you understand and have options for these disruptions as they continue to arise. So it's very important to understand what that partnership, who your GPO is, and how you can partner with them. Because many things that the GPO will help you with regards to the math problem are there rebates? Is there pricing? And then you add in the other piece of the puzzle, which is your distributor. So you've got the supplier, the distributor, and the organization that's going to receive the product. So we've really got a 3 or 4 variable process where we need to understand what role each of them play. And I encourage you to look at those and know who those partners are so that you can connect with them. So to know what your commitments are, what your requirements are, so what you can expect in return with regards to payment. So then you might think, well, how do I go about looking at anything that I want to evaluate from a value analysis perspective, whether it's a new product, a change of a current product, or let's say you're taking on a new service line. Let's say you're bringing on bariatrics or robotics. So we at Premier in the guidebook, which is on the Premier Inc. website, and you can certainly access it here as it's listed as a reference. We have a contract complexity overview, and that really helps you determine how complex is this particular category, because you might hear people say, well, a category is a category. Well, those of us that know particular categories, that's not the case. Some categories, because of the complexity of the products, the across multiple disciplinary use, whether there's known guidelines from certain regulations that are need to be enhanced, that you can use this as a vehicle for determining how complex is this category contract going to be. So I'm not going to read you some of these, but some of these, if they're not complex, it's the same supplier. But I would encourage you to look at that. So it would be great if we didn't have roadblocks that are thrown in our path. But as you can imagine, and as we've dealt with over the last 2 years, there have been many roadblocks, not just from product disruptions, but from our colleagues, our partners, our clinical partners that are just not so interested in making any change. I did have a colleague say, we don't want to ever waste a good pandemic. And one of the things the pandemic did tell us was that my personal preferences, personal clinical preferences, are not necessarily, I can use any mask. I might be particularly comfortable with a particular surgical mask. If I can't get that mask, then another mask will work. So this helps us understand the reason for roadblocks, but we need to have an identified path in the event that those submissions are needed. So it's best to be planning for those when you don't have to implement those. As I talk to suppliers and our members, I talk about we are in a 3-stage. We need to understand how we got here. We need to understand what we need to do today, but we also need to be looking at the future. And I think that's the true value of value analysis, to help us understand how we got here, understand what we can do today, but most importantly, understand what we need to do to position our organization for success in the future. So you can see on this one, it talks again about that multiple disciplinary VAT team that has the stakeholders at the table so that they can be heard. As you listen to stakeholders, I had a recent meeting with some physician stakeholders, and as they were talking about it, one of them commented they appreciated the opportunity to share their thoughts. So I knew that we were setting the stage or setting the table for a more positive transition in the event that we needed to transition from one product to another. So as we continue on in the next slide, you'll see that we need to understand if there's going to be potential delays in decisions. Are these roadblocks going to cause that? If they are, what is my next best go-to? What does my plan include for dealing with potential delays? What would the lack of the clinical stakeholder involvement, how would that impact this? So it's so important to get that critical stakeholder involvement early and often. Have a backup plan. If I can't use this, if I don't have this, based on my value analysis process, what's my next best product? Hudson talked a bit about standardization and the need for that and how that helps us smooth out these choppy waters around products, practice, suppliers. But as we all recognize, that's difficult, but it can be done. And then always share the output, share the work that you're done, share the work that your value analysis teams are doing so that you'll have sufficient C-suite involvement. You'll have sufficient involvement across the multiple disciplinary players, and that they'll understand the importance of value analysis being at the table and value analysis being included in the decisions. So as we move on, you'll see that we're going to begin to talk about some important processes or steps in the value analysis process. I talked a minute ago about having a chair and having a co-chair and having it being structured. That begins with the value analysis charter. What is our charter for our value analysis program at our local level? I can't stress enough, as Hudson laid the ground for us, about the multiple disciplinary teams, the multiple disciplinary committee. We have a standard agenda, we report on that agenda, we provide minutes, and that we can, not last but least, but have a process for evaluation of products and service. Because in today's world, service is just as important as process. So as you look at how really easy is a conversion. So we've talked about the math problem, and you talked about some products, some things here that are in the math problem. That would be staffing cost. The staffing costs have certainly risen in the last several months, maybe a year, and really is an important part of that math problem. I can't stress enough the inventory logistics. We had lived in a land of plenty and a land of just-in-time inventory. As we've seen the struggles with delayed inventory deliveries, the struggles with the logistics in general, I would encourage you to look at that and see if your just-in-time now really still is going to be supporting the delivery of care. Then you'll certainly want to make sure you look at the impacts across the continuum. And what are the interdependencies between the suppliers or the products? You know, the butterfly effect. If you do this upstream, what is that going to do downstream? And are there other areas that that's going to be going to impact? We can't, as you've heard some common themes through Hudson's and my comments, it's been communication, training, and education. Communicate, 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 train, 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 and provide education and opportunities for all the team to understand the value analysis tenets, how they impact not just infection prevention, but the entire health of the organization. Rewriting and revisiting policies. Prior to leaving the IDN that I spent many, many, many years in prior to joining Premier, I thought I'm going to look at how long does it take a policy to be revisited and rewritten and instituted. And I would encourage you just to do that at your own facility. It was an eye-opening experience for me to see how at that time, now this has been 13 years ago, at that time we had the luxury of time 13 years ago. I would charge to say, I'm not sure we have the luxury of time that we had 13 years ago. So we need to also understand what the changes in the cost structure are. And last but not least, could you look at reprocessing or sterilization implications? You know, in many areas of our care continuum, you have that reprocessing versus sterilization or sterilization or single-use devices. So I would encourage you to look at all of these portions of the math problem as we look through the value analysis process. So as you move on, there are 4 steps in the value analysis. And the first one is identify. What is the need? What does my GPO say about it? Are there standardization opportunities? What are my policies? Very important are what are the evidence-based practices and the guidelines? What does an organization like ASPAN or AORN or APICS or ARM, what do any organizations say about the particular practice? then you certainly need to understand and have line of sight to the capital budget, to the saving opportunities, and to any strategic initiatives in the event that you're going to start a new service line, that you need to be able to have your value analysis teams be well armed in what those strategic initiatives are. And certainly, as we've seen over the last several weeks, the implications of labor impact. As we move to the next step, which is gather information, this is where we gather all kinds of information and data. And Hudson talked about the importance of data and having the data with the intent to use. And I always talk to colleagues about, the data story. The data is going to tell us a story around benchmarking, around other standards, around cost, around reimbursement, around the number of use, the days on hand. How many days do you use? There are so many points in the data. So I would encourage you to make sure in this important step in the value analysis that you gather data, you gather the important data, you do a literature review or a literature search so that you understand what opportunities there are out there in the published data. And last but not least, as we've talked about, review and update your policies, procedures to make sure they are supported by the current guidelines for any particular organization. So as we move to the analyze step, you'll see here that this is where some of your GPO partners come in, the cost analysis, the negotiations, to identify the price versus lease, if it's appropriate for capital. Then are there opportunities for consignment or supplier managed inventories? What evaluation do our staff need? What evaluation opportunity did our staff need to be able to use this particular product? How do I develop evaluation parameters? Is it possible to develop a standardized evaluation form? One of the things that you might be aware of is the suppliers are out there and they will provide evaluations. You may want to review that to make sure it captures the parameters that are important for you and your organization. And then share all this data with your committee so that you can make a data-driven decision. And then the last step is to monitor what you determined to do. On the next slide, you'll see that implement what you determined to do. So you implement the strategy, you look at a logistics plan, you include the partnership from your distributor, you develop an execution plan and training plan. You've seen policies and guidelines and procedures on all of these. And then as Hudson advances to the monitor step, it is important to monitor the changes that we've made, that they do remain congruent with what we said we were going to do. So on the next slide, when it talks about monitoring the cost savings, the quality, make sure you have a baseline, especially with regards to infection prevention. Hudson talked about central line care. So you would want to know what your baseline information is so that you can have ongoing surveillance. To review what your compliance metrics are, evaluations, and any clinical, financial, safety, quality outcomes or impact metrics that are germane to the product. So as we move to the next slide, you'll see that we wanted to just provide some additional considerations prior to Hudson doing our wrap up. It's important to have a robust value analysis program. And I would say that this is one, as we've talked about, this multiple disciplinary, that talks about cost and quality, to include physicians. I recently had worked with some members that have physician-led value analysis. So I would encourage you to embrace your physician partners, your SME partners, to look at what are the important criteria in the product selection, not just cost. Cost is part of the equation, but your product selection is not built only on cost. And as we talked about, there are long-term implications that you need to make sure you're aware of as you're making these decisions. To look at improved accuracy in the documentation and coding, to be familiar with your hospital's current payment program and how they're currently reimbursed. And last but not least, to continue to expand and improve your reach outside the hospital walls, outside of the acute care setting. Because as we have seen over the last several years, the care is being delivered in places outside of the traditional hospital walls. So on the next slide, you'll see that we once again talk about the table. Who's at the value analysis table that include the infection preventionists? It starts with our leadership engagement, your C-suite. It certainly has your physician partners. It certainly works with your organizational alignment and your operational alignment. And last but not least, one of your most important partners can be your supplier, your vendor, and I would also include, while not necessarily a vendor, but your GPO partner. You can always go to for additional information to AVAP or ARM for additional information. I would encourage all of you to look at our AVAP website and the ARM website for additional information. So Hudson, I'll turn it over to you to recap.
Awesome. Thanks very much, Karen. I think that was such a great overview of the value analysis process. And we want to just quickly summarize what we've talked about during our short time together. We know that absolutely one of the most important collaborations, especially in today's era of this post-pandemic state, is the need for collaboration between infection prevention and control and value analysis, right? We share the same goal. I think Karen, as an experienced value analysis professional, as a GPO professional, as somebody who works at the sort of national scales of value analysis, has articulated that beautifully. We have that shared goal, right? We're trying to improve those clinical outcomes, reduce costs, reduce length of stay, improve the patient's overall experience, and prevent these very preventable healthcare associated infections. We also recognize, right, that there are ever-changing regulations and standards and guidelines that come out. And so this requires a pretty sustained focus on the terms of infection prevention and control in terms of product usage and how we evaluate those. We may have a product that meets our needs today, but it certainly may not meet our needs in 5 years. And so we want to be always looking for continuous quality improvement. Certainly one of the most important elements of this process is, as Karen mentioned, to have the right people sitting at the dinner table. We want to have infection prevention and central sterile processing and pharmacy and environmental services and some of these other partners that really are integral in our success in reducing healthcare associated infections sitting at our value analysis committee tables, right? We should also train these individuals so that they have a good overview and understanding, a working knowledge, if you will, of the overall value analysis process. And last but not least is check again, triple check, quadruple check, whatever you do to ensure that what you're trying to do and what you're trying to accomplish is actually feasible, that you are accomplishing those goals, and that you're meeting all of your external requirements, whether that's from regulators or other accreditation bodies. Karen and I provided some additional tools and resources for you here. So here are references. These are live hyperlinks, so you're welcome to click those, and those will take you directly to those important elements of those different organizations. I've also included the FDA's organizational chart here in case you're looking for how a particular product that falls under the FDA's bucket for regulation is really classified, right? And so that's helpful there as well. And you'll notice that the HICPAC evaluation tool for products for healthcare infection prevention is also included. And again, we'll make that available to you as a PDF after today's program. If you do have additional questions after today, feel free to reach out to myself or Karen. You can see our email addresses are listed here. With that, I'll turn it back over to our moderator, and thank you for the opportunity to share this information with you today. We hope you enjoy the rest of the symposium.
To earn your contact hour of nursing continuing education associated with this session, you will need to take and pass the 10-question true-false test with a grade of 90% or better. To get started, click on or copy and paste the URL into your internet browser to be taken to our CE portal. You will be asked to register, and then you will be directed to the test. If you pass, you will be able to view, download, and save your certificate. If you do not pass, you will have a total of 5 attempts to retake the test. You may store and share your grades and certificates for all sessions in the portal and access them by using the unique links provided at the end of each presentation. If you have any questions, please email me at kelly@healthcarehygienemagazine.com. We are now opening up our Q&A session. With us today is Hudson Garrett and Karen Niven. And as we wait for the first question to come in, why don't we talk about what you both see as the biggest regulatory barrier in terms of infection prevention product selection?
I think right now it's simply keeping up with all the different changes. FDA certainly plays probably the largest role in the regulation of infection prevention products. EPA also plays a role specifically with disinfectants and cleaning agents. But, the ability for the government to respond quickly is not one that they're excelling at. Let's just say that. And so there's a lot of moving parts and pieces as they relate to not only COVID, but specifically all infection prevention and control products. And I think at the facility level, there has to be a regulatory analysis of, does this product meet sort of the efficacy requirements? Does it meet the requirements of my facility and my clinicians? And also, is it going to meet the fundamental either state or federal regulatory requirements in order to be used? You can't just go buy a disinfectant that's not EPA registered, as an example. You can't use the medical device in a patient for surgery that's not FDA cleared. And so we have to work collaboratively with our partners at FDA and EPA, but also need to see more and more guidance related products to product selection come out of organizations such as the CDC that will provide a little bit more clinical context to how these products will be applied.
Terrific. So we have our first question that has come in. It is, how should complex healthcare systems adjust their definition of value in a post-COVID era?
Value before was defined by different people as different things. Now, I think if you think about the tangible value of products and services, certainly patients have an expectation that costs will go down. They won't continue to skyrocket in their mind. But as healthcare systems, we have to think about value as both the tangible and intangible. We may be able to save products cost, be able to save process cost, but there's also a cost of how the care is perceived. And what I mean by that is things like the HCAP scores, the infection rates, the patient satisfaction engagement indexes that we use. And that is all tied back to value as well, because at the end of the day, if the patient doesn't think they're getting good value for their money, they can go elsewhere. That's the thing in healthcare. It's like a fast food restaurant. You can go down the street and go to another one. Doesn't mean that they'll have all the same services and the providers that you want, but there are options. And so as we emerge from this COVID-19 pandemic, it's really, I think, critical that we think about doing things completely differently, where we put the patient at the center of the value and then put everything else around that, so that as we deliver good, high quality and safe patient care, we're able to also take costs out of the system and deliver a better product and value and make it more affordable for all.
Great, thanks for that. Could you perhaps go back and explain what role specifically the CDC, the FDA, and the EPA play when it comes to product regulation, please?
Sure. So FDA is the Food and Drug Administration. So as the name implies, it's going to regulate food and drugs, but it also regulates other things such as medical devices, the biologics, blood supply, amongst other different things. And so they are the biggest regulatory body that regulates products that are used in healthcare. And so essentially the way I think about it is anything that's used inside the human body or on the human skin is going to be under the jurisdiction under FDA. The EPA, on the other hand, is going to regulate disinfectants and cleaning agents. And so this includes pesticides, right? So even hospital or healthcare grade disinfectants are regulated by the EPA as antimicrobial pesticides. And so they've got a pretty stringent regulation protocol around that, where they'll approve the manufacturer's information, they'll look at independent laboratory data, and then also information such as the safety data sheet. The CDC, on the other hand, though, is not a true regulatory agency. And so they're really more providing the clinical context and guidance as to how these types of infection prevention products can be used in a clinical setting, whether that be a hospital, an ambulatory surgery center, a long-term care facility, it doesn't matter. But keep in mind that CDC guidance is not binding. It's not mandatory. It's not like OSHA, where it's actually part of regulation. And so, in sort of summary, the FDA and EPA do provide regulation. They provide regulatory approval. The CDC, again, is more of that clinical backbone to help us apply those context of those products in the specific clinical setting in which we work.
Great. So we have a question here. Would it be a fair statement that in principle, the same guidance from the CDC product assessment that you've shared today could be applied to something like purchase services or even support services as well?
Absolutely. I mean, it could even be something as basic as the patient's time. I know for myself, and I'm sure you'd agree with this, that when you go to your provider's appointment and your appointment's at 9, you expect to be seen at 9. Not 9:15, not 9:20, not 9:45, because time is valuable. And as my grandmother used to always say, time is the most precious asset that we never recover. And so the fundamental sort of, I guess, unit of value is time. And so whether that's time of a provider doing a procedure, the time actually to use a specific product, the time a patient spends actually receiving care, the time that it takes a nurse to do follow-up care, all of that is part of the overall concept of value analysis. But I think my take-home point is that we have to focus externally as much as we focused internally. And historically, value analysis has been really more of an internal facility-driven decision and sort of process. And right now, the patient is looking to see, what are we doing differently? What have we learned from the COVID-19 pandemic? How have we adjusted and adapted and frankly become a more agile workplace environment? And some facilities are doing this extraordinarily well. Others, not so much. And I think that's going to be the bandwagon that we've all got to get on, that we have to justify not only our existence, but the value of care that we're able to provide to the patients and do it in an efficient manner.
And our next question, what have you found to be the most effective way to bring the message that although a disinfectant is hospital grade, it is still a disinfectant and they all have potential risks and use? And how do you weigh all of the factors? What do you think?
Yeah, the term hospital grade is specifically a regulatory term. So it's one that EPA proposed years ago when they were introducing this concept of an antimicrobial pesticide that would be used in healthcare settings. And there were essentially 3 pathogens that you had to test against. That was by no means an appropriate representation of what's truly needed in the clinical setting. And so think of it more as a benchmark to use that particular term by, but it does not guarantee the efficacy that's needed in today's modern healthcare settings. So, it's more of an entry point than it is a sort of threshold that we have to meet. That in terms of how these products are used, you want to look at all of the different organisms, right? Your gram-positives and your gram-negative bacteria, your enveloped and your non-enveloped viruses, your pathogenic fungal organisms, your bloodborne pathogens, which are required by law. And then you could also look at certain spores, like C. difficile as an example, where you have some level of sporicidal activity that can be helpful. And so that is going to be more of a facility-driven conversation, really based on the antibiogram of what isolates are we currently finding in patients, and how do we need to deal with those that might be readily found in the patient care environment and stop their spread.
Our next question is, we've all heard about the importance of antibiotic stewardship. From your perspective, is there a similar principle for disinfectant stewardship?
So certainly there's always a risk with any chemical if it's misused, right? Whether that be an antibiotic that we give orally or through an IV or through an intramuscular injection. there can also be a same risk with any type of chemical that's misused. What that risk, though, is going to be different because of the mechanism of action, which is very, very different from an antibiotic that's put into the human body versus a disinfectant, which is used externally on a non-living surface. Because it's a non-living surface, the chance and potential for disinfectant resistance is going to be very, very different, much lower. That being said, if you were to, for example, dilute inappropriately a disinfectant, or you weren't mixing it correctly and you were getting below what we call that minimum inhibitory concentration consistently, then there would be that potential possibility for disinfectant resistance. And then there's been several studies on this in the literature globally looking at appropriate versus inappropriate use of disinfectants. That being said, there are pathogens that require specific types of disinfectants as well. Things like C. diff as an example, norovirus is another one that comes to mind, where we may need to use a specific type of sporicidal product in order to inactivate those germs. But when used correctly and when used according to the manufacturer's instructions for use, the potential for disinfectant resistance is extremely low.
Great. Next question we have, in your opinion, is the guidance that was provided by CDC's HICPAC regarding the 5 criteria for choosing a disinfectant, is it still accurate today, or is there any updated guidance that should be used?
So I would actually direct you to the guidance that's several years old from HICPAC, which is the Healthcare Infection Control Practices Advisory Committee, that looks at overall product selection. That is definitely something that is a very helpful tool that's agnostic of the type of product or technology that you're evaluating, but it gives you a very specific methodology to work through in order to guarantee that you're looking at all of the important elements of product selection, not only clinical, but really looking at sort of more of the operational pieces. And I think that's where organizations such as AVAP and ARM come into this, because they bring sort of that clinical value analysis perspective, and AVAP specifically, to drive down into how do I take this product and use it within my health system, do it safely, do it efficiently, and do it in a cost-effective manner. But that's actually where I'd recommend going, because it's going to give you more of a holistic view versus just something on disinfectants.
We have a question for Karen. Do you have any words of wisdom or insights to share with the audience today?
Well, the question is kind of the overarching question that I run everything through my mind is, how do we intertwine and interweave the value analysis process into whatever the situation that we come to in a healthcare delivery system, whether that's a disruption, whether that's a policy change, whether that's a infection prevention, whether that's a never event, whatever that is, how do we make certain that the value analysis thinking is at the table?
We have another question for Karen. What role would value analysis play in long-term care?
Well, as healthcare has changed, and as we have pushed so many things outside of the acute care walls, and who would have ever thought 15 years ago we would be doing total knees and total hips and sending them home or to a short-term rehab that very day? I was practicing clinically in the PACU when we began to send our cholecystectomies and thyroidectomies home that day. And I thought, we have lost our mind. But we have continued on that path. So I cannot imagine how it would be if we did not carry that same level of practice, concern, and looking at total value to be outside of the walls. As you think about long-term care and so many of the long-term care patients and residents are set up to be vulnerable. And who needs value analysis any more than our vulnerable patients? They are the most vulnerable. Many of them, they don't have the resiliency that you and I have, and many of the folks listening to this webinar, but they do have the need for a system that provides reliable, repeatable, consistent quality. And value analysis is the answer to that journey to be able to provide that on a consistent basis.
We have a question in for Karen. Will AVAP's tools and resources work for long-term care as well as acute care?
Absolutely. Absolutely. I think that our, the horizon is so big, and value analysis is so prevalent in everything we do, because like we've talked about a couple of different times, it's the way we do all things. And I just cannot imagine a world without value analysis. I cannot imagine a profession without value analysis. Quite frankly, I cannot imagine healthcare without value analysis.
Great, thank you. So that's about all the time we have today. If you have any additional questions, please send them to me at kelly@healthcarehygienemagazine.com, and we will do our very best to get them answered by our presenters. We will also include them in a transcript of this Q&A that will be available for download shortly. We thank our presenters and we thank all of our attendees for your time today, and we'll see you at the next session. That's a wrap for today's sessions. We hope you found them to be engaging and thought-provoking. We will make transcripts of the chat sessions available on demand shortly. And just as a reminder, if you missed any of today's program, you will be able to return to the event platform for the next 90 days.